The operating room is silent except for the beeping of the monitor and the sound of your own breathing. You've done this surgery 412 times. You don't count anymore. Your hands just move. But tonight something is wrong. Not with the surgery. The surgery went perfectly. With the name on the chart. You're standing in the scrub room. The procedure is done. The patient is in recovery. Stable. Breathing. Alive. And you just realized you operated on the wrong person. Not because you were reckless. Not because you were drunk. Not because you didn't care. Because the hospital made an error. The scheduling system mixed up two patients with similar last names. The wristband was on the wrong chart. 3 nurses checked. Nobody caught it. But you're the one who held the scalpel. And now the clock is ticking. Let's back up. You are Dr. No Name. 12 years of practice. Board certified. Not the flashiest surgeon in the hospital, but the most reliable one. The one they call when it needs to be right, not fast. Tonight's case was a routine appendectomy. Scheduled for 9 p.m. Patient. Marcus Webb, 44. Mild abdominal pain. Textbook presentation. You scrubbed in. You said hello to the anesthesiologist. You glanced at the chart. You began. 40 minutes. Clean margins. 0 complications. You closed, stepped back, and let the team finish. Then you walk into the hallway and you see him. A man in a hospital gown. Sitting in a chair outside room 7. Arms crossed. Looking annoyed. You recognize the face from the intake photo. Marcus Webb. Your patient, the real Marcus Webb, never went into surgery. You stop walking. Your brain does what brains do in moments of catastrophic clarity. It rewinds the last 2 hours frame by frame and shows you every place it could have been caught. The intake nurse. The pre-op nurse. The anesthesiologist's checklist. Your own pre-incision timeout. Every checkpoint failed. And you realize something else immediately. The man you just operated on, the man currently in recovery, had no medical reason to be there tonight. You opened him up for nothing. You pull up the system. Hands moving faster than your thoughts. The other patient's name is Daniel Rourke, 43 years old. Similar last name structure in the database to Marcus Webb, both flagged for the same ward, same night. A scheduling conflict generated a wristband error that cascaded through 3 departments. Daniel Rourke came in tonight for a pre-surgical consultation. Not a procedure, a consultation. He was supposed to go home with a pamphlet and an appointment card. Instead, he went under general anesthesia. And you removed a healthy appendix from a man who had nothing wrong with him. Here's what you know about Daniel Rourke right now. He's stable. The surgery was textbook. His appendix was healthy, but it's gone now. He'll recover fully. He has no idea what happened to him. He's going to wake up in about 40 minutes. And here is the question that starts burning through every layer of your professional training. Do you tell him immediately? Because here's what telling him means. It means a formal incident report. Tonight, before he even opens his eyes. It means the hospital's legal team gets called. Risk management. Administration. It means your name, your license, goes into a database that never forgets. It means Marcus Webb, the actual patient, needs to be rescheduled and operated on, probably by someone else, while his appendix continues to deteriorate. And it means Daniel Rourke, a man who came in for a consultation, wakes up to the worst news of his life. You stand in the hallway. The clock on the wall reads 10:47 p.m. You have maybe 30 minutes before he wakes up. You need to understand something about how hospitals work. Because right now your brain is saying, this wasn't my fault. And in many ways, it wasn't. The wristband system failed. The scheduling software failed. 3 separate nurses failed the pre-op verification protocol. The anesthesiologist failed the timeout check. You are the 6th person who should have caught this. But here's what medical law says and what you already know, deep in your gut. The operating surgeon bears final responsibility for confirming patient identity before incision. The Joint Commission, the WHO Surgical Safety Checklist, your hospital's own policy manual. All of them say the same thing. Before you cut, you confirm. Name, date of birth, procedure, site. You did the timeout. You called the name. Someone on the team confirmed. But here's what you're realizing now. Did you look at the wristband yourself? Or did you trust the nurse's verbal confirmation? You're trying to remember. You're standing in a fluorescent hallway at 10:49 p.m. trying to reconstruct 40 minutes ago. And you can't be certain. This is the moment the weight shifts. Because a system failed, but you are the one holding the scalpel. And in every court, in every licensing board hearing, in every peer review, the scalpel is where the responsibility ends. And there's something else. Daniel Rourke, the man in recovery, is going to need a story for why he has a surgical scar when he wakes up. His family is going to ask. His primary care physician is going to ask. Insurance is going to ask. There is no version of this where nothing is said. The only question is what is said, and who says it first. You make a decision. You call the attending nursing supervisor. You say 4 words. We have a problem. Within 15 minutes, the charge nurse, the anesthesiologist, and the department head are standing in a side room off the recovery ward. Nobody is looking at each other. You lay it out. Calm. Clinical. Because that's the only way you know how to talk about things that are destroying you. The department head's first words are not, "Is the patient okay?" His first words are, "Who else knows?" And right there, that question tells you everything you need to know about the institutional instinct. The anesthesiologist says the surgery was clean. No complications. The patient will make a full recovery. From a purely physiological standpoint, he is fine. The department head starts talking about documentation, about what gets written in the chart versus what goes into the incident report versus what stays in this room. He's not suggesting a cover-up. Not exactly. He's suggesting delay. A careful, structured delay. Let risk management craft the disclosure. Let legal review the language. Let the patient be stable and comfortable before anyone says anything. He says, "We have 48 hours before formal reporting is required." He says, "Let's use them correctly." And he looks at you, because you are the attending surgeon. You are the one who signs the operative report. You are the one whose name goes on every document that flows from this room forward. You can feel the weight of that pen before it's even in your hand. You go back to the system, not for legal reasons, for human ones. Daniel Rourke, 43, software project manager, married, 2 kids, ages 9 and 11, based on the emergency contact form. He came in tonight after his primary care physician noticed mild elevated white cell count in routine blood work. Referred him to general surgery for evaluation. Nothing urgent. Nothing alarming. He drove himself to the hospital. His wife doesn't even know he's here. He's going to wake up in a room he didn't expect to be in, with a pain he didn't expect to feel, from a surgery he never agreed to. He signed a general consent form during intake. The kind that covers emergency intervention. The hospital's legal team will argue it covers this. You think about what it means to wake up and have something taken from you, physically permanently taken, that you didn't know you were giving. Your appendix is vestigial. Surgeons remove healthy appendixes prophylactically in certain procedures all the time. Physiologically, Daniel Rourke has lost nothing he will miss. But he didn't choose this. And you did it. Daniel Rourke opens his eyes at 11:22 p.m. You're in the room. You didn't have to be. Nobody asked you to be. The department head specifically suggested you let the patient liaison handle initial recovery communication. But you're there. He looks at the ceiling, then at the 4, then at you. He says, "Did something happen?" You have rehearsed nothing. Because you made a decision back in that hallway while everyone else was talking about documentation and delay. You decided that if you were in that bed, if you were the one who woke up with a scar, you would want the person who put it there to be looking you in the eye when they told you. So you tell him, not the legal version, not the managed, liability-softened version that risk management will spend 3 days crafting. You tell him what happened, clearly, without deflection. You tell him the hospital system failed. You tell him you failed. You tell him his surgery was performed without his specific consent for this specific procedure. You tell him he is medically stable and will recover fully. And you tell him you are sorry not as a legal formulation but because you mean it. He doesn't say anything for a long time. Then he asks, Is my appendix gone? You say, yes. He looks back at the ceiling. He says, I want to call my wife. You hand him his phone and you leave the room. The formal incident report goes in that night. Your name is on it. The hospital's legal and risk team is notified before morning rounds. Marcus Webb, the actual patient, is contacted. His appendix is evaluated again. He is scheduled for surgery the next morning with a different surgeon at his request. The procedure goes without complication. Daniel Rourke retains a medical malpractice attorney 4 days later. The case does not go to trial. It settles 18 months after the incident. The terms are confidential. Your license is reviewed by the state medical board. The investigation takes 8 months. The board finds a systemic failure with contributing negligence at the physician level. You receive a formal reprimand, not a suspension, not a revocation, a reprimand, which is entered into the permanent public record attached to your license. The anesthesiologist receives the same. The hospital implements a new dual verification protocol, physical wristband confirmation by the attending surgeon, captured on a checklist with a timestamp before every incision. It is now mandatory. It is named informally after the incident. It will prevent this from happening again. You keep your license. You keep practicing. But you think about room 7 every time you do a pre-op timeout. Not as punishment, as a reminder of what the protocol is for. Here's what gets left out of every incident report, every legal brief, every board review. Daniel Rourke came in that night scared. Not dramatically scared, quietly scared. The kind of scared that comes from a routine blood test that came back slightly off and a referral you didn't expect and a waiting room you sit in alone because you didn't want to worry your wife over probably nothing. He was supposed to go home. The system that failed him was built by human beings, maintained by human beings, checked or not checked by human beings. And the one human being who had the last, clearest opportunity to stop it was you. The department head was not wrong that the system failed at multiple points. He was wrong that the answer to a systemic failure is a managed delay. You were not wrong that the surgeon bears final responsibility. You were not wrong to go into that room. The question medical ethicists have debated for decades is not whether to disclose. Full, immediate disclosure is the standard legally, ethically, professionally. The question is, what do you do with the guilt that survives the disclosure? Because Daniel Rourke accepted the apology. He pursued the settlement. He moved forward. And you with the clean record and the intact license and the new protocol named after your worst night, you have to decide what this changes about who you are in that operating room. Every single time. You made it to the end of this, which means you've been sitting with this decision the whole way through. So let me ask you directly. When Daniel Rourke opened his eyes, when he looked at you and asked what happened, would you have been honest immediately the way the surgeon in this story was? Or would you have waited for legal to craft the disclosure? Would you have let the institution manage it, argue to yourself that a cleaner, more careful explanation protects him too? There's no easy answer. People who believe in the system say, let the process work. People who've been in that bed say, just tell me the truth. So tell me, what would you have done? Drop your answer in the comments. I read every single one.